Good evening, everyone, and welcome to this session number 3 of the Nclex New Generation Review series. My name is Dr. Tom Madayag. I know there's only 3 or 4 of you that is in attendance, but many more are viewing the videotapes or the video recordings. So let's go ahead and get started so that we can end on time. So the topic that we're going to discuss today, which was the case study, is going to be diabetic ketoacidosis. So this is going to be one of those areas that usually comes out in the examination for the NLEX. For those of you who haven't had the opportunity to do the case study questions, so we're going to go through it at the end of this presentation, but you can also access it on the link that is illustrated or on the slide itself. Okay? All right. So the purpose of this review course is to make sure that you are familiar with the case study format that the NCLEX New Generation questions have. And this particular case study questions is going to evaluate your ability to recognize cues, to analyze cues, to prioritize hypotheses, to generate solutions, to take action, and to evaluate outcomes. So before we go to the material, I'd like to ask you a question. So I'm going to have a poll. All right, and if you could just answer for me. All right, so we have a scattering of answers, and so let's go ahead and begin the class, because I wanted to make sure that we all have a basic understanding and where you are coming from. And so soon you will find out what the correct answer is. All right, diabetic ketoacidosis is obviously a complication of diabetes mellitus. It's an acute major life-threatening complication, and the characteristics of this particular condition includes hyperglycemia, ketoacidosis, and ketonuria, or ketones in the urine. So those are the 3 things that are going to be present whenever we have diabetic ketoacidosis. Again, hyperglycemia, ketoacidosis, and ketonuria. Now, it actually happens when an absolute or relative insulin deficiency inhibits the ability of glucose to enter the cells for utilization as metabolic fuel. And therefore, what happens is that the liver rapidly breaks down fat into ketones to employ as a fuel source. Now, there's one problem with utilizing fat as a fuel source, and that is going to be the offshoot of that particular fuel, and that would be ketones. These ketones cause them to accumulate in the blood and urine and turn the blood acidic. And so, whereas diabetic ketoacidosis occurs mainly in patients with type 1 diabetes, it is not uncommon in some patients with type 2 diabetes as well. So the correct answer to the question was it occurs in both type 1 and type 2 diabetes. So once again, I wanted to go back for clarification on what I had said about what happens when the metabolic fuel that is utilized is going to be fat instead of glucose. So I'm just going to write something over here. Now, if this is a cell, usually what happens is the cell utilizes glucose as a source of energy. And glucose actually is going to be transported from the absorption of carbohydrates that we have taken in And from the bloodstream, it usually goes into the cell through the passive transport of insulin. Now, because of the fact that you do not have insulin, or you have essentially a deficiency of insulin, what happens then is glucose cannot enter the cell. Thus, the body has to look for other sources of fuel. And the source of fuel is going to be from the liver. The liver breaks down rapidly fat, and the fat becomes the fuel of the cells. And the offshoot of the fuel of utilizing fat is going to be ketones. Now, there's no problem when glucose is utilized, because usually our byproduct or end product of metabolic activity is going to be carbon dioxide and water, which could easily be eliminated by the body. But in the case of fat, what happens is ketones, I don't know what's happening here, but anyway, the ketones are going to be utilized as fuel, and therefore this is going to cause the formation of ketones, which is going to be absorbed both in the bloodstream as well as in the urine. And therefore, this also causes acidosis. Are you having some problems with the slide, or is it just on my end?
Just on your end.
Oh, okay. It's flashing, and I don't understand what is happening. So anyway, let me just hold on one moment. There you go. All right, for as long as you see the slides, it's going to be okay. Now, what is the pathophysiology of diabetic ketoacidosis? So again, there's an absolute or relative lack of insulin. And as a result of the lack of insulin, there's going to be an increase in your counter-regulatory mechanisms, because the body has to find out how else to produce energy or to look for fuel. And so glucagon, for example, is going to be released, as well as cortisol, growth hormone, and epinephrine. These are regulatory hormones that would try to counter-regulate the lack of insulin. And of course, as I said, the hepatic metabolism of free fatty acids is now going to be utilized, and ketones and ketoacidosis is going to be produced. Metabolic acidosis occurs, and when metabolic acidosis occurs, it results in respiratory compensation. And this respiratory compensation is actually the one that causes the classic respiratory pattern of patients with diabetic ketoacidosis. And that is what is known as Kussmaul's respirations. Now, I want to emphasize that Kussmaul's respirations is actually a pattern of breathing as a compensatory mechanism to blow off the acid. So as you could see in patients with diabetic ketoacidosis, they have a prolonged expiratory phase. So they breathe like this. And this is an effort to blow off the carbon dioxide. All right, so what happens to serum potassium? Do you all know what happens to serum potassium? Let me do one thing. Let me just disconnect this first. And wait, two. All right, sorry about that. Just one moment. I apologize. Just one moment. There is a problem with my second screen here. Okay, great. Hmm. Hmm. Okay, I think we are back. All right, can you see my screen? Are you able to
No,
see the pathophysiology? Not yet? Okay.
no,
All right, so one moment. Okay, how about now?
yes.
Oh, okay, you can see my screen now? Okay, good, good. So let me just do this. All right, so we already talked about the pathophysiology, and I think that I've already talked about that. And so let's move forward to the next slide. So I think this is a visual of what the pathophysiologic process is when we have, of course, diabetic ketoacidosis. It all
Is that
starts with
gonna, I'm sorry, is that gonna explain the serum potassium? You were going to do
Oh,
that.
yeah, I was talking about serum potassium. Great. Thank you so much. All right. So what happens to serum potassium and why? I'm glad that you stopped me. Okay. So whenever we have acidosis resulting from obviously the production of ketones, what's going to happen is so if this is the cell, and this is the vascular bed, the blood vessels. So usually potassium is intracellular. It's going to be the most abundant intracellular electrolyte, and sodium is outside of the cell. Now, when you have a lot of acids, so when you have a lot of acids, what happens is that the acids will now go into the cell. So what happens to the potassium? The potassium gets out of the cell. So initially then, whenever we have acidosis, it leads to hyperkalemia. However, there's one thing that you would have to remember, that in diabetes, because of the lot of glucose that is going to be in the bloodstream, what's going to happen is it's going to pull fluid from the cells. And therefore, it causes your polyuria. So with polyuria, what happens eventually with your serum potassium? The serum potassium will now go down. And that is why it's critical. In diabetic ketoacidosis, we need to find out what the potassium level is of the patient all the time. Okay, so that was the intent of that question: what happens to serum potassium and why? All right, so going back to the pathophysiology of diabetic ketoacidosis, as you see, there's going to be hyperglycemia, and there's going to be an increase in plasma osmolarity or osmolality. So if you remember, osmosis is the movement of water from a lesser concentration to a greater concentration. So what does that mean? So if the cells have a lot of fluid right here, and the vascular bed has a lot of glucose, what's going to happen is that the water from the cells are going to move into the vascular bed. So what happens to the water or the fluid level in the cell? The cells become dehydrated. So that's one concept that I want you to remember, that whenever you have hyperglycemia, therefore, there's going to be osmotic diuresis. The osmotic diuresis would cause the dehydration of the cells. Okay, so that's the intracellular dehydration that is mentioned over here. And of course, because of the increase in plasma osmolarity, you would have an osmotic diuresis. Now, when you have diuresis, you're going to have a decrease in your extracellular fluid volume, which therefore leads to acidosis, and then, of course, to shock. And as a result of the osmotic diuresis, you will also have electrolyte loss. And that is why in diabetic ketoacidosis, electrolyte monitoring is always going to be very important. Okay? All right. So what are some of the causes of diabetic ketoacidosis? DKA can occur in patients with diabetes mellitus, most frequently associated with relative insulin deficiency. So diabetic ketoacidosis therefore occurs more frequently with type 1 diabetes, although we must say that approximately 10% of cases occurs in patients with type 2 diabetes. So what are some of the common risk factors that can precipitate the development of extreme hyperglycemia that usually ends up in ketoacidosis? While the most common scenarios for diabetic ketoacidosis is when the patient develops an infection. Infection is commonly an inciting factor in diabetic ketoacidosis, because when you have an infection, the body needs more insulin. And because of the fact that the patient does not increase their insulin dose, what happens, therefore, is they develop diabetic ketoacidosis. The other reasons might be non-adherence to insulin therapy. A lot of patients miss or have disrupted insulin treatments, and therefore this could cause diabetic ketoacidosis. Or sometimes missed insulin is the most common cause. In particular, who do you think are the ones that usually forget their dose of insulin? It usually are the adolescent population. So this is a very, very critical problem among younger patients. Other causes of diabetic ketoacidosis may be major illnesses like myocardial infarction. Maybe the patient has sepsis or pancreatitis or any traumatic injury or anything that stresses the physiologic mechanisms of the patient. And the use of certain medications such as glucocorticoids, steroids, for example, are going to cause an increase in blood sugar. So therefore, this is going to be something that we need to emphasize to patients, that they should not take steroids without the knowledge of their provider. And believe it or not, sometimes patients don't even know that they have diabetes, and this might be the first time that they are knowing that they're diabetic, because this is going to be the initial presentation. Okay. So what are the signs and symptoms of diabetic ketoacidosis? Well, the first thing that we need to do is going to be remember what the hyperglycemia is going to do. And that is going to cause your polyuria, number one. But it also will incite your hypothalamus to stimulate the thirst reflex, and therefore there's going to be polydipsia. Okay, so polyuria is going to occur as a result of the increase in the extracellular fluid compartment temporarily, and then, of course, the polydipsia, which sometimes is more severe than the polydipsia. Dehydration is going to be one other symptom, and this could be manifested by fever, dry skin, mucous membranes that are also dry. The patient will have decreased perspiration because of the cellular dehydration. And I must say that abdominal pain is also a common complaint in diabetic ketoacidosis, in addition to the ones that are listed in here. So the breath usually is going to have this sweet odor to it. It's almost like an acetone type of odor. And so we describe that as a ketone breath or an acetone breath. Because of the dehydration, you're going to have tachycardia, as well as tachypnea, and of course, the other symptoms that are going to accompany it, which includes your abdominal pain. So those are the most common signs and symptoms of diabetic ketoacidosis. All right, so let's go to the poll over here. Okay, so I'm going to end the poll. You remember what I said, the most common reason why patients usually are going to have DKA is going to be an underlying infection. So they have an infection requires an increase in insulin dose, and yet they don't increase the insulin dose, and therefore that is the most common cause. All right, so what are the physical examination findings whenever you have a patient with DKA? Well, on physical exam, most of the patients with ketoacidosis present features of hypovolemia. And the hypovolemia is from either renal loss as well as GI loss. In severe cases, patients may be hypotensive and actually in frank shock. And they may have a rapid and deep respiratory effort, as I said. And this is as a compensatory mechanism. And this is what is known as Kussmaul's respirations, right over here, or Kussmaul's breathing. So the purpose of the Kussmaul's breathing, again, is to blow off the excess acid. And their breath also have distinct odor to their breath, mainly because of the excess in acetone production. And of course, a history of rapid weight loss is a symptom in patients with newly diagnosed type 1 diabetes. You remember that some people actually are going to have this as a primary presentation. They don't even know that they have diabetes, and all of a sudden they are on DKA. And so usually these patients who find out that they have diabetes from having DKA is preceded by a rapid weight loss. So this is a symptom in patients with newly diagnosed type 1 diabetes. All right. So we had talked about the signs and symptoms as well as the history and physical. We're now going to look at the laboratory workup of patients that are going to be on DKA. So hyperglycemia is the typical finding at presentation with DKA. but patients actually can present with a range of plasma glucose levels. However, the definition of DKA is going to be hyperglycemia, and hyperglycemia is going to be defined as a blood glucose above 200. So I'm just going to write that down because it's going to be important for you to remember. So in order to have DKA, what you must have is hyperglycemia. And this hyperglycemia is usually a blood glucose of over 200 milligrams per deciliter. And, or I should say plus, metabolic acidosis, plus ketonuria, and ketonemia. Okay, so these are ketones in the blood as well as in the urine. So this is going to be the typical findings of diabetic ketoacidosis. Now, the ketonemia is defined as a ketone concentration of greater than 5 MEQs per liter. Okay, so this is the hallmark. Remember, blood sugar over 200, ketones of 5 MEQs per liter or over, as well as metabolic acidosis. So when we have metabolic acidosis, what is our pH finding? The pH finding is going to be less than 7.35. Let me write that down. So your pH must be less than 7.35. And the bicarb is going to be, of course, diminish, right? Or decrease. So less than 22. Okay. So whenever we have the laboratory values of these ones, we also have to find out what is happening with the anion gap. And anion gap is something that I'm going to explain in the next slide very briefly. I don't want to confuse you, but the laboratory value that we follow whenever a patient has DKA, more importantly than glucose, is actually your anion gap. Now, are you all familiar with anion gap? I know that you're familiar with identifying whether or not a patient has hyperglycemia. Okay, so let's go over, and I'm going to come back to this slide in a little bit, but I wanted to talk about anion gap before we go further. All right, in the body, we have a principle called Isohydric Principle. And Isohydric Principle says that in order for equilibrium to happen in the body, the number of positively charged ions should always be equal to the negatively charged ions. So positively charged ions are cations. So cations should always be equal to the number of anions. So it is illustrated over here on this part of the slide right here. I'm going to zoom it in. Do you notice that sodium is 142? It's a positively charged ion. It's a cation. And potassium is also positively charged ion, calcium and magnesium. So if you add this, 142 plus 10, 152 plus 3 is 155. These are the number of positively charged ions. How about the negatively charged ions? It includes your bicarbonate, which is 25, your chloride, which is 105, phosphate, which is 2, sulfate, which is 1, and other organic acids, which is 6. It also totals to 155. So do you understand that? In the body, we always have a balance of anions to cations. But look over here. There is actually more of the, if I'm going to draw this part right here. Notice that the unmeasured ions are going to be more over here. So the difference between the two, see this? If you disregard these electrolytes and measure only the unmeasured ions, there are more anions than cations. And the difference is usually around 10. So this is 13 right over here. And this one 16, 22, 23, 25. So the difference between this is around 12, correct? This is what's called an anion gap. Am I clear so far? This is what's known as the anion gap. So what is the normal anion gap? The normal anion gap is up to 12 milliosmoles per liter. Okay. So what does that mean? It still doesn't mean anything to you, right? Okay. So when we have acidosis, what are the two causes of acidosis? Well, it's either because you have an increase in acids, or you could have a decrease in bicarbonate. Do you understand that so far? Hello? Yes, okay, good. So what happens is that whenever the acids is the problem, an increase in acids is the problem, then that means to say that you have a high anion gap acidosis. This is what is present when you have diabetic ketoacidosis. So your anion gap must return to 10 to 12. That is the object of your therapeutic interventions in patients with diabetic ketoacidosis. So the question is, when a patient has diabetic ketoacidosis, which one do you monitor most importantly? Is it the glucose or is it the anion gap? And the answer to that is the anion gap, because we are trying to determine whether or not the acidosis is improving or worsening. Okay? So I'm going to say that if a patient came in with diabetic ketoacidosis and the anion gap is 22, all right, so what is the cause of this 22? An increase in acids, right? All right, as I give therapeutic interventions, this one should go down to 10 to 12, to the normal range of normal. Okay, so this is the objective of anion gap, this as a laboratory measure. Okay, so over here, the lab evaluation, it says that the anion gap is going to be increased. So if you could see at the bottom, right over here, the more severe the acidosis is, it's going to be more than 12. Okay? All right. The other thing that we monitor for patients with the DKA is sorry about that, your serum osmolarity. So do you know what serum osmolarity is? Okay, so serum osmolarity measures the amount of particles in a solution. So supposing that this is blood and we have particles over here, glucose and other things, if we measure its weight, this is what's called osmolarity. Okay, so when you are dehydrated, does your serum osmolarity increase or decrease?
Increase.
It increases, okay? So that means to say that you are going to be dehydrated. So an increase of serum osmolarity is dehydration. When you have a lot of fluid, then that means to say you have a decrease in your serum osmolarity. That is correct, Madayag. It also follows the BUN. Similar to BUN. When you have an increase in a decrease in your fluid, your BUN is going to go up. All right. If you have a lot of fluid, your BUN is going to go down. So good. I'm glad that you were able to relate that. So there's going to be an increase in your serum osmolarity because of the cellular dehydration. And then, of course, the other tests would be your CBC, your ABG, your urinalysis, and so on. But the most important thing that I want you to remember is to monitor the ketones, to monitor the anion gap. What's the number that you want the anion gap to be?
10 to 12.
10 to 12. Very good. You want it to be between 10 to 12. And that is the normal anion gap. And then, of course, your serum osmolarity is going to be something to detect or to determine the status, the fluid status of the patient. Okay. So I'm glad that we got that already out of the way as far as the anion gap is concerned. Okay. So let's go to a poll right over here. All right, how about the others? Okay, so you remember the answer here is letter C. You remember that DKA is defined as an increase in the serum ketone concentration above 5 MEQs per liter. So letter C is the correct response. And then, of course, a blood glucose over 200, and then the pH is going to be acidotic. So over here in letter C, we see that this is going to be correct. The blood glucose above 250 or above 200 is correct. And a pH of 7.3 is going to be acidosis. This is alkalosis right over here, right? And this is alkalosis, and this is acidosis. So both of them are going to be acidosis. The correct response is going to be letter C. All right. The thing that makes the letter D incorrect is that it says that the ketone is 7 MEQs. You remember the ketones has to be more than 5 MEQs. All right. All right, so what is the treatment or the management of patients with diabetic ketoacidosis. I want you to remember the acronym DKA because that determines the order at which you are going to treat the patient. So D stands for dehydration. After initially stabilizing the circulation, the airway, and the breathing as priority, the specific treatments are going to be the following. You're going to have, of course, your dehydration. And so with dehydration, what you need to do is, of course, give fluids, correct? All right. So we give boluses of fluids. And as you could see over here, it's going to be necessary up to the time that you reach a serum glucose of around 12 to 14 milliosmoles per liter. Now, this is expressed in milliosmoles, but if you translate this to milligrams, it's easy. The formula for that is you multiply always by 18, this number. So this one, 12 times 18, for example, would be equal to 216 milligrams per deciliter. So depending on what Nclex shows you, it's either the milliosmoles per liter or the milligrams per deciliter. They're nonetheless going to show you the normal values. Okay, so you don't have to memorize that. Okay, so as we correct, when your body has a lot of sugar, your blood vessels have a lot of sugar, your vascular bed, and you give now a lot of fluids, what happens to your blood sugar? So there's a lot of glucose over here. You give a lot of fluids, it's going to decrease, right? And that's the reason why, my friends, you are not going to treat DKA with insulin first. Let me repeat that. In DKA, we never treat it with insulin first. We always treat it with fluids for several reasons. Okay? And the first reason is, of course, the fact that there is cellular dehydration. So usually when we reach around the 200 mark, we're going to add dextrose or D10 water to the IV. So you're saying, are you crazy, Dr. Tom? This patient already had hyperglycemia, and now we're coming down, and you're telling us to give dextrose as an IV fluid. Okay. The reason we want to do that is because we don't want to rapidly correct the dehydration, the hyperglycemia. And there's a reason to that. When you correct hyperglycemia rapidly, what's going to happen is the brain does not resolve the hyperglycemia right away. And so what happens is that fluid will rush to the brain and it will cause cerebral edema. Okay, so let me explain that in detail. So when you're treating a patient with a blood glucose of, let's say, 300, and you give fluids, so this is the vascular bed and this is the brain. So the glucose here now is going to be less, but the brain's glucose is still a lot. So which one is more concentrated, the brain or is it the vascular bed?
Brain.
The brain, okay. So where does water go? From an area of lesser concentration to an area of greater concentration. So fluid will now rush into the brain. And when it does, it causes cerebral edema. And therefore, the patient will die as a result of this. And that is the reason why we do not want to rapidly correct the hyperglycemia. Okay, so that's a very important item to remember. All right, the next thing that we're going to do, let's go to the fluids first, dehydration, right? So as far as fluids are concerned, we usually give isotonic sodium chloride or Ringer's lactate. And as you could see, we are aggressive in giving 1 to 3 liters during the first hour, 1 liter during the second hour, and 1 liter during the following 2 hours, and 1 liter every 4 hours. So as you could see, we gradually decrease the amount of IV fluid that we're going to give until the patient now is going to have a good blood pressure. Now we switch to 1/2 normal saline. So why would we switch to 1/2 normal saline? Do you know why we need to switch to 1/2 normal saline? Okay, so there are 3 types of solutions that are used in the... something happened again to my... There you go. All right. IV solutions are going to either be isotonic, hypotonic, or hypertonic. An example of an isotonic solution would be normal saline. An example of a hypotonic solution would be 1/4 normal saline. And a hypertonic solution would be D10 in W. Okay, so what's the difference between these solutions? All right, when you give a isotonic solution, so if this is a cell and this is the blood vessel, an isotonic solution is mimicking the amount of concentration in the vascular bed and also in the cell. So in an isotonic solution, there is equal exchange of the fluid. So you're just mainly maintaining exchange of fluids. However, when you give a hypotonic solution, so this is a hypotonic solution, if this is the cell, and this is going to be your vascular bed or your solution, IV solution, it has lesser concentration than your cell. So where does fluid go in then? Go to? Where does the fluid go to if you give a hypotonic solution? Does it stay in the vascular bed or does it go to the cell? Okay, I'm going to tell you, this is more concentrated. The cell is more concentrated, so the fluid will go in here. So if you want to feed the cells, if you want to bring the water into the cells, what you need to do is to give a hypotonic solution. And that's exactly what we need, right? Because of the fact that we had cellular dehydration. Okay? And then, of course, if we give D10 and water, what happens is that if this is, again, the cell, we're giving a hyper-concentrated solution right here, like D10 and water. So therefore, what's going to happen is we're going to dehydrate the cell. So if we want to pull the water out from the cell, we need to give a hypertonic solution. Okay? So that's exactly what's being referred to over here, that once the patient is euvolemic, meaning to say that we have enough volume in the vascular bed, we now have to feed or not feed, but to make the cells hydrated. And that is why we switch them to 1/2 normal saline. Okay, so this is important. Why is it that we have to switch to a hypotonic solution after euvolemia to hydrate the cells? That is the answer. Okay, all right. Then, of course, when the blood sugar is less than 200 to 250, we now are going to be concerned about preventing cerebral edema. So we now add dextrose to the IV solution. So either a 5% dextrose or a 10% dextrose. All right. So we never start treating the patient with DKA with insulin first. No, it's always fluid first. All right. Okay, I'm going to pause there to see if you have any questions at the moment. Okay, so you have a patient who has DKA, and the orders are for you to start normal saline, 10 units of IV regular insulin bolus, an insulin drip protocol. The labs are showing a pH of 7.25, a glucose of 455, and a potassium of 2.5. Which is the intervention to perform next? All right, your answers? Oh, I haven't launched it yet. Okay. Okay, everybody answered starting the IV fluids. Okay, and that is wrong. And I will tell you why it's wrong. Letter B is the correct response. So let's find out why that is. Remember that when insulin is given, what happens is that it takes the potassium back into the cell. So you remember the sodium potassium exchange in cells? If this is a cell, right, when potassium is in here and sodium is in the extracellular compartment, usually, right? And the way that potassium goes into the cell is when the insulin is present. Okay? So when insulin is present, glucose moves into the cell along with potassium. So you had a potassium of 2.5. Is this normal or is this abnormal? It's abnormal, right? Okay. So this is your vascular bed and your potassium here is 2.5. Now you gave insulin. When you gave insulin, what's going to go into the cell right there? Glucose and what else? Potassium. Okay. So this 2.5 will now become 2.0. What is the danger? The danger is that the patient is going to be in severe hypokalemia. The patient will have a cardiac arrest. So when you have a low potassium level, you should correct the potassium level first before you give insulin. Okay, so fluids first, correct. How low is too low? Okay, so anytime the potassium, normal potassium is 3.5 to 4.5. In some laboratories, it's 5, right? anytime your potassium is at a level of 3 or less, it is going to be too low. This is critical. It has got to be corrected first before insulin is initiated. Okay? All right. So there are several items that I'd like for you to remember. And the first one is the priority intervention for patients with DKA is D, to treat the dehydration. K is to treat the potassium. See, that is the order of how we would correct the situation. All right. All right, going further, the last part of the treatment is going to treat the acidosis. And the acidosis is going to be resolved with the administration of fluids, as well as the correction of potassium abnormalities, and also with the administration of insulin. So insulin therapy includes the administration of insulin, and we only use the short-acting insulin. This is the one that we use to correct hyperglycemia. Now, we do not want to use subcutaneous insulin because absorption through the subcutaneous route is reduced in diabetic ketoacidosis because of the dehydration. And therefore, using intravenous routes is preferable. So usually, you do not need to remember the concentration for the IV infusion, but usually we mix a regular insulin in a 60 ml of normal saline, and we usually infuse it at 15 ml per hour. Obviously, there are protocols that each hospital is going to follow, or each physician is going to order, and therefore this is just as a general example of how we would administer the insulin drip. Right. Now, we maintain this insulin drip until the blood
Excuse me,
glucose.
Professor.
Sure,
I'm
sure.
sorry.
That's okay.
The insulin, I was trying to remember, we never do a wait, where was my bolus? We never do insulin in a bolus, right?
Yeah, you could give an insulin bolus. So if you look at the previous slide, over here, I'm going to go over. Yes, we give a bolus of regular insulin. Yeah, you could give it. All right. So we don't want to rapidly correct the hyperglycemia, because what was the problem again? If you rapidly correct hyperglycemia?
Too much fluid in the brain.
Yes, cerebral edema. Very good. That's going to kill the patient. All right. So we do not want to allow the blood glucose level to fall below 200 because of the danger of creating cerebral edema. Okay. Now, in the event that the blood glucose falls below 50, then what happens is that this is hypoglycemia, which could be a complication of your giving your insulin. And therefore, what's going to happen is that we need to give 10% dextrose in order to correct the hypoglycemia. Okay. And then, of course, we still maintain the insulin drip. We don't cut it off abruptly. All right. I think somebody asked this question. See over here, this is the one that I was looking at. We usually give a bolus of 0.1 units per kilogram of body weight. So the bolus is given, and then an infusion usually follows. All right. So
okay,
that should answer your question. All right, so it's now 7 o'clock, and I really would like to have a 5-minute break So let's go ahead and have a 5-minute break, and then we will continue with the acidosis part of the DKA, how we correct it. Okay? 5 minutes. Okay, it's 5 minutes, and so let's go ahead and continue. So we had talked about treating the dehydration first, and then treating the electrolyte next, and so or the potassium, and the last one is treating the acidosis. So this is usually accomplished by the by correcting the hyperglycemia with insulin. So we start with insulin therapy, and over here, as you could see, we must always correct the potassium before starting insulin. And we already talked about what is usually the intervention or the dosage of insulin that's going to be given. So I'm going to go back to the electrolyte component once again to make sure that we had completely understood what we were trying to say. Patients who have DKA have to have serum potassiums drawn every hour. We need to monitor the potassium hourly. And of course, usually the potassium, when we have to correct them, is usually given by IV drip. And it is usually initiated if the potassium is going to be between 4.5 to 6. We still need to give potassium, thinking that with the administration of insulin, what happens to the potassium? It goes into the cell. Okay, so we keep the potassium higher than normal. We don't want to keep it at 3.5 or 4.0 because we know that eventually that potassium will go into the cell. Okay, so that is the correction of the potassium. Now, do we give bicarbonate to patients that are DKA? So sodium bicarbonate is only infused if there is severe acidosis and it starts the patient to decompensate, particularly in patients with sepsis or lactic acidosis. However, it's typically not given in patients with diabetic ketoacidosis in the absence of sepsis because of the fact that there's going to be improvement eventually of the acidosis with insulin and the electrolyte treatment. Okay, so this is the reason why we don't give bicarbonate, and rapid and early correction of acidosis with bicarb may actually worsen hypokalemia because it now pushes the potassium again into the cell. Okay, so over here, your patient was admitted with diabetic ketoacidosis and has the following lab values. What is the best initial action for the nurse to take? Okay, I'm now going to do the pulse so that you could indicate your answer. Okay, I'm going back to the slide so that you could see the values. You already know what you selected as the answer. The correct answer is C, administer 40 MEQs of potassium chloride. And I think most of you got that correctly. This patient has DKA. where the blood glucose level raises due to a lack of insulin. And the treatment for DKA is to administer insulin. However, insulin moves glucose back into the cells. And therefore, what happens is that potassium also goes back with it. So you understood, obviously, the explanation. All right. As a result of overzealous treatment of patients, cerebral edema might occur in these patients when you rapidly correct the glucose. So it is a major complication that usually evolves anytime during the treatment of DKA. And this is more notable in children, okay? It affects children primarily. It is actually the leading cause of mortality in children whenever they have DKA. So we always are extremely cautious to avoid cerebral edema during the initiation of therapy. So we always have to monitor the neurological status, a deterioration of their level of consciousness in spite of your improved metabolic state usually indicates the occurrence of cerebral edema. So how do we diagnose cerebral edema? MRI is usually used to confirm the diagnosis, but the diagnostic criteria is the presence of these symptoms of abnormal response to pain, posturing with decorticate or decerebrate postures, central nervous palsies, abnormal respiratory patterns, and deceleration of the heart rate. All these are signs and symptoms of cerebral edema. And so how do we treat this? When we treat cerebral edema, we have to give, therefore, hypertonic solutions. You remember the action of hypertonic solution? Okay, so let's say that this is the cell. There is cerebral edema. There's a lot of water here. And this is the vascular bed. And we give mannitol or D10 in water. It's the same effect. When we do this, we are now going to pull the fluid back into the vascular space. And therefore, it resolves the edema. Okay, so those drugs are mannitol and hypertonic saline solution, like 3% saline solution or D10 in W is also going to be hypertonic solutions. Okay. All right, the correct answer here is going to be your potassium. So letter B is the correct answer, the prevention of hypokalemia. The other electrolytes like sodium and, of course, your calcium should also be corrected as needed. But if serum potassium is not monitored and replaced as needed, life-threatening hypokalemia may develop. Cardiac arrest is the #1 problem that's going to be associated with it. Okay, so the correct answer here is letter A, and that's going to be our next point of discussion very briefly. These levels of blood glucose is not found in DKA. It would be found in another situation known as hyperglycemic, hyperosmolar, non-ketotic syndrome. And we're going to talk about that next. All right, I think you all got it. It's all the three elements, right? Ketones in the urine and serum, metabolic acidosis, and Cosmos respirations. Okay. Great. All right. The correct answer is letter D. I will check my glucose every 3 to 4 hours and take liquids when I'm sick. All right. So let's now go to the next complication of diabetes, which is similar to, but not the same as DKA. And this is what is known as hyperosmolar hyperglycemic state. Oh. So this is one of two serious metabolic derangements that occurs in patients with diabetes mellitus. It's similar to DKA, however, it has a much higher mortality rate than DKA. So you heard that correctly. It's much more serious than DKA. So what happens with hyperosmolar hyperglycemic syndrome? Well, there's hyperglycemia, hyperosmolarity, I already talked to you about that, and dehydration. But there is no ketoacidosis. That is the difference. So there's no ketones in the urine, and there's no ketones in the serum. Most patients present with severe dehydration and, of course, neurological deficits. So this is going to be the other complication of diabetes, either type 1 or type 2. So in type 2 diabetes, the body still produces some insulin, and it is usually enough to avoid ketoacidosis, but not enough to control glucose. So when the serum glucose rises, osmotic diuresis begins to deplete the body fluid. So remember again, why is there diuresis? Well, again, if this was your vascular bed right here, there's a lot of glucose. And so in the cells, there's a little bit of glucose. So what happens is, because this is highly concentrated, it pulls all the water from the cell. So again, you have cellular dehydration. And when fluid goes into the vascular space, what happens? You will now have a lot of fluid to pee. And this is what we call osmotic diuresis. Because of the osmotic diuresis, you now have to deplete body fluid. So you will now have dehydration of both the cells as well as the extracellular fluid compartment. So this is what is happening whenever you have HHS. So what's the difference between the two? Okay. So the difference between the two is this. So let me just zoom this in. As you could see in patients with diabetic ketoacidosis, it usually evolves rapidly within 24 hours. The HHS develops over several days, and the signs and symptoms are almost the same, except for there's no Kussmaul's respirations in HHS, because you remember there is no ketonuria. And of course, the classic symptoms of HHS are your polyuria, polydipsia, weight loss, and volume depletion. So I think you can look at the signs and symptoms, and one of the most compelling signs and symptoms is the fact that in HHS, because of the severe increase in glucose, there's going to be neurological symptoms that are going to be observed. And they might include lethargy, for example, focal signs and seizures, obtundation, as well as coma. And I'd like to zoom this in as a comparison. Notice that in HHNS, your glucose is going to be very high. Usually, your DKA is over 250, but it usually does not reach above 600. So if it is over 600, it is now HHNS. And notice that the ketones are usually absent, or if they're present, they're usually minimal. But in diabetic ketoacidosis, there's going to be an increase of your ketones in both your urine as well as in the plasma. Okay, so those are the compelling differences between HHNS and DKA. This is a tricky question. Okay, some of you answered HHNS and some of you answered DKA. All right, so where is HHNS usually going to occur? Is it type 1 or type 2? Usually in type 2 patients. And of course, it could also occur in type 1, but it's more on type 2 patients. DKA can occur in both, but it's usually in type 1 diabetic ketoacidosis, diabetic patients. Now, the patient is taking metformin. If a patient is taking metformin, what kind of diabetes or what type of diabetes does he have? And Francis said that it's type 2, and you're correct. So therefore, the higher possibility is that this patient is experiencing hyperglycemic hyperosmolar non-ketotic syndrome. Okay? All right. So the correct answer here is R, B, D, and E. Okay. So this goes again to the pathophysiology of diabetes. So you remember that in diabetes, glucose is not able to go into the cell. And therefore, what does the cell do? There's going to be an increase in glucagon that's going to be released. And then the liver is now going to break down fat or break down glycogen to be used as a fuel. And of course, the insulin deficiency is what causes the hyperglycemia to occur. So the correct answer is B. Answers are B, D, and E. Okay, so the signs and symptoms of HHS are similar to what we had talked already about to DKA, with some exceptions. The diagnostic criteria is this, and I want you to remember that anytime the glucose level is above 600, it's no longer DKA, but HHS, right? So the others are going to be minor, but the most important thing is that you have to remember that the serum glucose has got to be over 600 in order to qualify as HHS. All right, I'm out of poll questions. The poll only limits me to a certain number, so you could just indicate your response in the chat box. So what's the most important and compelling assessment that you need to do in a patient with HHS? Your answers? Just put it in the chat box. Okay, the correct answer here is cerebral edema. The treatment of HHS requires medical observation and care because water goes back into the brain cells. And this poses a threat for cerebral edema. The other signs and symptoms are also manifestations of HHS, but this is the priority. You remember, this differs from DKA because it has neurological symptoms. Okay. All right. So the treatment is going to be hydration, electrolyte management, similar to DKA, IV insulin, and of course, to identify the precipitating factors. I'm not going to go over how much we're going to give as far as fluids are concerned, because we already talk about that when we talk about DKA. So it's similar treatment. Fluid administration actually will cause the plasma glucose level to decrease even without insulin administration. In fact, a decrease in the plasma glucose is a sign that we're adequately replacing the fluids. All right. Which of the following patients is most likely experiencing HHS based on their symptoms? Okay, letter D is the correct response. The reason is you remember this 600 milligrams per deciliter. All right, Francis has a very good question. Which lab signals cerebral edema? Now, actually, it is not going to be the laboratory that will suggest to you that the patient is going to have cerebral edema. Rather, it will be the neurological symptoms. So let me just go back to that slide as far as the neurological symptoms are concerned. And because that's what you have to actually monitor in these patients. So over here is going to tell you that there's going to be presence of cerebral edema. And you remember the confirmatory diagnosis is going to be made by MRI or CT scan. Okay, so that's a very good question, Francis, and thank you for raising it. All right, the treatment with insulin is going to be the same, and also the electrolytes as well. So HHS would have all of the following signs and symptoms except. What do you think is the correct answer? Yes, letter D. Kussmaul's breathing is found in DKA due to the fact that it's a compensatory mechanism of the respiratory system because of the acidosis. So remember that in DKA, there are excessive ketones. This is not present in HHNS, and this causes metabolic acidosis. Good. So we already talked about the electrolytes, and of course, this is going to signal us to go to our case study. So let's go ahead to our case study. So two of you answered the case study, and therefore you're familiar with it, but let's go ahead and read it. A 73-year-old male with a history of type 2 diabetes presented to the emergency department due to a change in mental status. So the nurse notes at 12 o'clock, this is a 73-year-old male with a history of diabetes type 2, brought to the ED by spouse for changes in mental status from his baseline. The client's wife reports that he woke at 6 o'clock to complete his morning routine. At approximately 11, he became unaware of his surroundings and began sweating profusely and slurring words. Breath sounds are clear but noted with a fruity citrus odor. This should tell us something. And deep, rapid respirations. Sinus tachycardia per cardiac monitor. He's awake and alert. Pupils are equal and reactive to light. So notice the temperature is 99.5, the pulse 118, respirations 32, 97 over 66, and 89% on room air. The patient is on sitagliptin, metformin, or Januvia with metformin, and valsartan 160 milligrams PO daily. So those are his medications. Which four findings are most significant? So let's see, could you type your responses, what you think are the four most critical or most significant findings? So we're only looking for four. Okay. So I got your responses. The lung sounds are, it says, breath sounds are clear. So this is not going to be one of them, correct? History of type 2 diabetes. Oh, because of the fact that he is having this fruity odor and deep rapid respirations, well, this certainly is going to be significant, isn't it? The history of type 2 diabetes. And the respirations, as far as the fruity citrus odor and deep rapid respirations, are going to be a significant finding. The other thing that I think is compelling here is that the blood pressure is down 97/66. So this might be appropriate. The pupils, there's nothing mentioned about the pupils. The temperature of 99.5 is febrile. It might be a manifestation of dehydration, but the mental status is more significant than that, isn't it? And then, of course, the medications are not compelling at this time. So the correct answers here are history of type 2 diabetes, the respiratory status, and the circulation. So because the client has a history of type 2 diabetes, the nurse should follow up with the signs that the client's diabetes may be out of control, such as the deep and rapid respirations, the acetone breath, and the mental changes. The low BP and the tachycardia can indicate dehydration. So that's the correct answer. All right, let's go now to the next frame. So here's the laboratory report. And now the nurse starts on IV and reviews the labs. For each finding, click to specify if it is consistent with ketoacidosis or hyperglycemic hyperosmolar syndrome. Each finding may support more than one condition. Each column must have at least one correct option. Okay, so let's take a look at the pH. Is there acidosis in ketoacidosis? Well, obviously, we said acidosis, so there is, right? But this is not present in HHS. That's what differentiates it. There's no acidosis, there's no production of significant ketones in HHS. How about the blood glucose? Well, the blood glucose over here is 435. And so would a blood glucose of 435 classify as ketoacidosis? Yes. Would it classify as HHS? No. Why? What is the magic number for HHS? 600. Yes, 600 or above. All right. And the serum creatinine, the creatinine is 1.9, which means to say that the patient is dehydrated. Is there dehydration in ketoacidosis? Yes. Is there dehydration in HHS? Yes. And how about the urine? It says the urine is positive for ketones. This would obviously be found in ketoacidosis, but it should not be present in HHS. Okay, so this is how we would answer this particular question. All right, so now it's 12:15 and the patient 12 o'clock, I'm sorry. We did that, the 12:15, voided 30 mL dark amber urine, sent for urinalysis, comprehensive metabolic panel, CBC and ABG, IV of normal saline started, 2 liters O2 started per nasal cannula, capillary glucose is 440. All right, and these are the laboratory reports. So let's see what the next question is asking us. Complete the sentence. the problem the nurse should address first is do you remember the algorithm DKA? Which one should you correct first?
Dehydration.
Yes, we need to have the algorithm dehydration, the potassium, and then the acidosis last. Okay, so therefore, the correct response over here is restoring the volume. All right, so we need to correct the dehydration first. Okay. So the client is diagnosed with ketoacidosis and the nurse begins the plan of care. And this is the next question. The client is diagnosed with ketoacidosis. For each nursing intervention, click to specify whether the intervention is indicated, contraindicated, or non-essential. Okay. Glycosylated hemoglobin, A1C. What is glycosylated hemoglobin A1C? It reflects the glucose status of the patient for the past 3 months. Are we interested in finding that out now? No, right? So it's non-essential. Very good, non-essential. And my pen is, okay, so right there. Teach the client pursed lip breathing. Now, what is pursed lip breathing and what's the purpose of pursed lip breathing? Well, pursed lip breathing is an effort to actually slow the pace of breathing and control the expiration phase. So pursed lip breathing, it's called pursed lip breathing because you inhale and you say, so you're trying to blow off carbon dioxide. Will that help? Will that help in this situation? Yes, it will help because it will try to remove some of the excess acid. So I think that the correct answer here is that it should be, it is indicated. Administer insulin glargine. What is insulin glargine? No, it's long-acting. We need a short-acting type of insulin and not glargine. So this one is going to be contraindicated, right? Because of the fact that this is going to not correct the problem. How about insert indwelling Foley catheter? Now, do you remember CAUTI? We do not want to routinely insert a indwelling catheter, right? So it's contraindicated because it's contrary to our CAUTI protocols. And how about administering IV potassium? Is potassium needed? Yes, it is, obviously. And how about monitoring the ECG? Anytime a patient is going to be very sick, we always have to make sure that we monitor the ECG for cardiovascular changes because acidosis usually could cause hypokalemia, and hypokalemia can cause arrhythmias, and therefore this would be indicated. Okay, let's go to the next one. And these are the orders. Admit to ICU, give 1,000 cc's IV normal saline, bolus over 30 minutes. Then start normal saline with 20 of KCl. Start regular insulin. after the fluid bolus, finger stick blood glucose hourly, titrate insulin infusion, obtain electrolytes every 2 hours, and continuous cardiac monitoring. The nurse reviews the order. What action should the nurse take while implementing the treatment plan? Select all that apply. Okay. So over here, what are we going to do? Select all that apply, it says. Begin insulin after the bolus of 9 units per hour. What did we say should happen first? You should hydrate the patient first, correct? So this would be incorrect. Should we anticipate holding potassium for low potassium insulin for low potassium levels? Yes, we already explained that we have to do that. So this would be correct. Request IV fluids with dextrose when glucose levels start to normalize. Why do we do this? To prevent cerebral edema. And that would be correct. Allow the client to eat when status stabilizes. Obviously, this is the best thing to do in order to prevent hypoglycemia. So letter D is going to be okay. And monitor for symptoms of fluid overload. Anytime we give boluses of fluid, right over here, we always have to monitor for symptoms of fluid overload. I'm sorry, Francis said after the bolus. It says after the bolus. See, start regular insulin after the fluid bolus. No, this bolus over here means to say that it's the insulin bolus, 9 units per hour. This is insulin, Francis, okay? So it's not referring to the fluid bolus. Okay, yeah, that you could easily misinterpret that because now this unit tells you that this is the insulin bolus. Okay. And now let's go to the last question. So we now have the vital signs over here and the laboratory report. And the nurse reassesses the client after giving a fluid bolus and starting the insulin infusion, which findings indicate the treatment plan has been selected, effective. Select all that apply. Okay, blood pressure, 97/66. At 12:15, it's 98/70. At 13:30, it's now 109/70. So does this mean to say that the blood pressure is a manifestation of the treatment plan working? And the answer to that is yes. Okay, the mental status, let's see. He's at 12 o'clock, he's awake alert. And at 13 o'clock, awake alert at 13:30. So this means to say that you remember that he came in with slurring of the words and unaware of his surroundings. So the mental status has improved. How about the breath sounds? Breath sounds are clear, So nothing really has changed with the breath sounds, right? How about the pulse rate? Pulse rate is 118 over here, 115, and then 100. When you have dehydration, you have tachycardia. So that means to say that when your pulse is going to decrease. That means to say that your hydration status has improved, right? So this is going to be okay. This is going to be a correct answer. And the capillary glucose, where's the glucose? 435 over here, and 440 over here, 435. It's still high, isn't it? So that means to say that it hasn't really improved yet. Okay. And the last one is the pain levels. The pain was not a primary issue. There was no complaint of pain at all. So I think that A, B, and D are the correct responses. Okay. And I think that ends my presentation. I want to thank you again for your participation, and I look forward to seeing you tomorrow. I also want to make sure that I tell you about my YouTube channel. I have a lot of information for people who are taking the Nclex, and so I invite you to visit it. And this is my YouTube channel under Dr. Tom Madayag. So once again, I want to thank you, and I look forward to seeing you again tomorrow. Okay? Thank you and have a great evening. Thanks.